Assalamu alaikum. I hope you have a lunch, good lunch. What's called, first of all, I'm from Qasim Hospital, Sharjah, as she said, and from Cardiac Surgery Department. First of all, I would like to thank Her Highness Sheikha Fatima bint Mubarak for hosting this conference. It gives me a great pleasure to be taking part in the Emirates Nursing Association celebration. I would like to thank them for making this celebration possible. I want to also take this opportunity to welcome all our guest speakers and our audience to the celebration. I would like to start by asking a few questions to our speakers, but I would like to begin with Dr. Hatem. Dr. Hatem Al-Amri is a manager of the Health Professional Licensing Department at the Health Authority Abu Dhabi and consultant pulmonary medicine, associated professor of medicine, UAE University, and editor-in-chief Emirates Medical Journal. Please, Dr. Hatem.
Bismillahirrahmanirrahim. Assalamu alaikum. First of all, again, I just thanks the organizing again for giving me the privilege to talk to you today. But as with my biography, I'm gonna take off the hats of all the basically the delegation that they give it to me, whether it's in the health authorities or in the universities. And I'm talking to you today as an educator because that's what I love. And probably I'm going to share some of my experience through the 3 years that I've been in the health authorities. Definitely when you look at the titles of evidence to actions, that means you have to do an action, you have to have all the data and all the evidence to do that actions. Whether this action is going to be a correct actions or it's a knee-jerk reflex actions, there is something that when you do any actions, you have to have all the data. And I think I'm going to share with you today the fundamental of building any medical healthcare services. It's the human aspect. So first of all, I'm basically saying how we can improve our human capital within UAE, but in particular within Abu Dhabi, because that's what I studied. We're going to look at the overview of the healthcare workforce within the Emirates of Abu Dhabi, and then what is the role of medical education to improve that such workforce. And I'm going to share with you a model that we went through for the last 3 years. And it would be nice to have your feedback when I finish all of this. When I started in the Emirates, basically, in the health authorities, it was a puzzle to me where to start. Something completely as a workforce planning. It's very understudied subject that most of you probably share. It's very complex. And if you put 10 people within the room to discuss about healthcare workforce, everybody going to come up with an opinion. But because we studied medicine, so the best thing is to simplify things up a little bit, and we look at equations. So to have a healthcare, you have to have a supply and a demand. And that's all the topics I'm going to discuss today, supply and demand. So let's look at the basically growing up of UAE. UAE, and I think shared with the other GCC countries, it basically started as a barely survived societies to innovation in almost 40 years. And Abu Dhabi is no exception. That actually there is a growing up population. And in healthcare, that growing population has been evident by having more healthcare workforce licensed within the Emirates of Abu Dhabi for the last 2 years. Overall, 33% increase. So that's a good news. But the bad news is we're still having demand. This is the projected needs for the Emirates of Abu Dhabi for the coming probably 2015, and you know that we basically, as a fertile population, we need around 1,000 midwives for the coming 3 years. We need a large number. around 13,000 nurses. We still have many areas that's underserved. We still have a disease burden that's actually still haven't been touched, and we have severe demand when it comes to high critical areas, ICU, intensive care, neonatal, and so on and so forth. And the integrated model of healthcare, which is patient-centered, it's been mentioned today, is not there yet. Actually, I call it here physician-centered. So patients actually have to look for physicians. And that's not the model that we are looking for. We're looking for patient-centered. Actually, all the services have to be delivered to the patient, not the other way around. And unfortunately, that means that we have to have an integrated system that's built within. To understand our system, we have to build it within, so be able to do that integrated system. So we are fairly to say that to have a healthcare workforce in the Emirates of Abu Dhabi, number one, it has to be sustained. And I'll show you what the challenge of being sustained healthcare. Number two, it has to be knowledgeable, skilled, and competent. And those are the three things that it is medical education. So you have to provide this to healthcare. But the final part is to have to be valued and operating within supportive environment. Supportive environment promoting evidence-based, as today, promoting patient-centered, promoting educations, continuous educations, and basically to able to maintain that healthcare within the system. So to know this, we know that now to have a healthcare providers, we need him to be in the expert to master level to provide the healthcare that we need. If I want to go to the doctor, my father want to go to the doctor, I want that healthcare provider to be an expert, whether it's a nurse, a pharmacist, a physician, and so on and so forth. That healthcare professionals have to be a level of being independent, experienced, leader, manager, scholar, and educator. And I think you all agree that this is basically the level that we all looking for. But that level has to be reached through a milestone. So let's share exactly what are the milestones of healthcare professions. So basically, a schooling that run around 11 to 13 years, that basically you learn the basics of knowledge, basic knowledge about everything. And after that, you have to go through some sort of undergraduate training, where now you have to concise all of this into more specialized format. And then if you are really lucky and you are really motivated, you will go further and do postgraduate, whether it's a master, residency, whatever it is. And this is actually probably the cream on the top of your cappuccino. That's what it is. That's the first step that you're going to have. The sweetest step that you have, basically this is what it is. The undergraduate is the top of everything. Whether you're going to have a master in your field or something else. But if we look how many people actually went through that track within the Emirates of Abu Dhabi, we find it's probably around between 7 and 10% that they went through with their own system. Basically, it's cooked home system. So we found that the Emiratis, and probably part of it, if we add extra, is the UAE graduates, from that system is around 7 to 10%. So 90% of the healthcare are not made up this way in our system. So they are the one which is ready-made, that comes in directly to this levels, the expert and master. They've been made somewhere else, and then they come and facilitate and provide to them the healthcare. And the same place is actually where the loss also happens. And there is very little when it comes to the complete track. And if actually having more interesting numbers, that actually look at the new license and the cancellation of licensing in healthcare sectors, in the private sectors, you find, for example, 1,000 new licenses being issued in year 2010, and there is 800 cancellation of licensing issued the same year. The 1,000 carry around 20% of the healthcare workforce within the private sector. And if you look at 2011, actually the cancellation of licensing is more than the new licensing. So what happened means, it means that there is a movement within the healthcare that actually does not provide the continuity of care. It is a problem. All of us share that if I'm a patient and I'm going to see a Dr. A today and then tomorrow I don't see him, that's a care that's not being provided. That's a care that's missing. So that supply again, if we go back to this, that supply and loss, it's a continuous process. So if we look at the bigger pictures, there is supply and different steps of all of this. And there is also loss in different steps. But the major steps is here. There is a little supply in here. When it comes to, at least Emirates Abu Dhabi, there is a little supply that people come in for doing postgraduate from outside. And there is a little supply coming in to do undergraduate from outside. And that's, I think all of us probably, I see people shaking their heads because that's probably what it is. So the first thing I want to share with you is exactly that the formula that I told you about in the first, now we need to implement this formula here. So to increase this levels, I need to still continue having these supplies, but still prevent the loss. I have to stop the loss. We all have to stop the loss of people in this levels. We have to stop the people retiring early in healthcare. And we have to provide this flow further. So, and prevent all the losses. Which is not an easy job, and it's not something that we can implement it now and tomorrow we're going to say celebrate that it's worked. It's 10 years. I think I'm going to show you at the end a few other examples. So I'm going to go to the model right away. We had a chance to produce something, to come up with something, and then as being a position in the health authority, we have all this vast majority of data and quote-unquote power. We may make something faster and quicker than probably anywhere else. So let me look at the physician aspect of it, because that's what we initiated the models. So in the undergraduate levels and across UAE, we have 5 universities that produce around 200 graduates of a young graduates, medical students that comes in as a young doctor. If we look at the postgraduates, in the Emirates of Abu Dhabi, we have around 100 posts to continue postgraduate for those 200. If you look further, so what we have in 2009, we had basically 75 applied to those 100 posts. So we already lost 125 that we don't know where they are. Number 2, even from those 75, 33 ended up having a residency post. So another loss. We're preventing people to come in the postgraduate, 2009. So we end up with underutilization of medical or educational posts that definitely will affect the people already existing within the medical education. If you are the only one at the class, this is not the class that you want to be. From the postgraduate levels, we have a problem with the program qualities. I'm not going to talk about details because I think it's just a matter of a concept here. So I'm kind of spreading with the details what exactly it means. There is no incentives for anybody to go through that track. The trainer does not have any incentives. And there is no strategies. Nobody knows exactly why we need actually to invest in such a track. We have supplies. People are coming every time, so why we have to invest something new? So we did, basically after having this data, now we're trying to do the actions. If we do something, does that equations changed? So with the team, of probably 1 in the first 6 months, and then 2 in the second year, and then now 3 with Yana added to the team. And over 3 years, 3 people basically sitting in that office trying to orchestrate something to come up. And we came with a model, which is, I think, Yana now is, my colleagues in the office is very much crowded with that. Businesses, we created the Tansiq, which is centralization of all residency programs, centralization of all registrations of people going to postgraduate through our office. So we're able to look at the map, what's going on. So I'm going to share with you some numbers, but I think one of the things that we did, we tried in this post to improve the incentives, to improve all the problems that I shared with you in the previous pages and the previous slides. So promoting medical educations, putting it as part of the strategies, partnership with the universities. We start to talk with all the national stakeholders, Minister of Health, Dubai Health Authorities, UAE universities. Recognition of residents from the licensing point of view. Residents is being now recognized as one entity, different than everybody else. Streamline the recruitment process, centralization of the process, as I said, elimination of licensing obstacles. It used to be that every graduate have to have 2 years experience to become a license. So where are we going to get the experience if we're not going to license them? Increase the number of posts. And first of all, when it comes to postgraduate, strong accreditations, facilitate the licensing process for those accrediting, improve the incentives, and harden the lead. When somebody is losing or somebody wants to get out from the programs, we actually make his life difficult. So it's not just going to become easy for anybody just to go to a program today and tomorrow leaves. So this is the slide that I'm proud of with my team, that in 2009, 2010, the posts available for training was around 100, 70 applied, and only 33 end up in those posts. So it's a 30% occupancy. When we start the process, we have 102, 125 applied, and 86 end up in the post. So we increase almost 3 times. In 2011, 2010, we have increased the number of posts. Application doubled, and with pretty much 100% occupancies. And just the initiation of this year, we have 460 applications. 460s, 3 years ago, there were 70s. So there are possibilities. I'm not really telling you that this is going to work or not, but at least from the evidence-based, there is a mind change, and there is an incentives, and nobody will enter a program unless there is a career path. And when you create that incentives, you create the pull effect. We did not push anybody. We did not let them come and apply. We just create that pull effect, and that pull effect worked. So to conclude, its healthcare workforce in the UAE is very complex, and I think it's understudied, and it's under let's say, we don't do anything about it per se. We push toward high strategies. We should look at things a little bit from the bird's eye view, rather than from snapshots that we always trying to do, like quick solutions. Should be data-driven, but we are not actually doing anything about data-driven. And the most important thing is customized. We have to understand the system, so we're able to customize it ourselves. And we should not use the push, we should use the pull. And I think I grew up 40 years ago when Sheikh Zayed Allah created that pull. He basically gave us salaries to go to schools, give us buses, meals, free. He did not really come and push everybody to go to schools. It just he created that vacuum that people start, there is nothing else except to go to schools. Families start to push their girls and boys to schools. That's the pull effect that we are lacking in medical educations. And unfortunately, we're not doing a good business in it. And IT, higher technologies, tourism, they're doing much, much better. So that's why you find now everybody go to the high schools. So where do you want to go? I want to go to Mubadala. I want to go to nuclear. I want to go to all those areas. Why? Because they created that pull effects. If you ask how many wants to be a nurse, if you hardly see anybody, I'll be actually surprised, and probably you're going to lose him in the middle of that milestones. Medical education is the core, and it is really the lever to make a change. And it's the same as evidence-based that I spoke with previously, that you're not going to see the tree growing very fast. As we've been studied 40 years ago, now I'm standing here because that's some product of that system. And I think all of us shared at one point that bull effect, that at one point now we're standing here because 40 years ago something happens. And I thank you very much for being patient.
Thank you. Thank you very much, Dr. Hatem. It was very beautiful and stimulating presentation. And the next speaker is Dr. Muhammad Nizam Iqbal. He's a specialist in pulmonary physician in Rashid Hospital in Dubai and lecturer in Dubai Medical College Medical Faculty. Please. And he's going to talk about term work by multidisciplinary team in clinical setup. Please, Dr. Iqbal.
Assalamu alaikum. And let me at the outset thank Ms. Jolly, Ms. Iman and the Emirates Nursing Association for inviting me here today to participate in your wonderfully organized Nurses Day, International Nurses Day. Congratulations. All morning we have heard various speakers talking about evidence-based medicine and practice. My job is just very easy. Let's all work together to make it a multidisciplinary team. So, go ahead and to start with, what we would reflect on is basically how evidence-based practice is a multidisciplinary effort, and how we should, as a teamwork, by the multidisciplinary team, will achieve success in evidence-based practice. We'll just look at the roles played by the various participants in a clinical setup and how these services integrate together to facilitate evidence-based medical practice. You'll just have a look at what online education and evidence-based librarianship is, how we are going to use this various CME websites, the websites which support decisions, like electronic decision support systems, electronic pharmacy systems. And last but not the least, we'll just reflect on what the indispensable role of the information technology services and support are. This was one of the article which came out in the Washington Post in 2006. This is a period when we had a lot of research coming out, a lot of medical research coming out and was being published. It was, let's reflect on it. It says, all breakthrough, but no follow-through. It reflects a reality where we had almost 90% of our researches which are not being used or implemented or irrelevant. We had less than 10%. In fact, some figures said 6% of research which was clinically valid and can be used. So, as an introduction, I would like to say, in our current health setup, in patient care involves the participation of various medical specialities. Now, a successful evidence-based practice will require the support of all these individual teams. And once we have a concordant working together of all these multidisciplinary teams, and we will be able to adopt the relevant and effective recommendations which are brought, and then we can put our evidence-based practice into a successful conclusion. Now, we know for sure, as everybody has talked, evidence-based practice will definitely improve the quality and care rendered to our patients, and for that, I suggest that a multidisciplinary teamwork is essential. Why? We have the multiple different health disciplines which are involved in the care of the same patient or the same type of patient or group of patients. These individual partners, they bring a set of dissimilar knowledge and skills. So they are different. We don't have an overlap of knowledge. The doctor's bringing in a set of skills and knowledge, and nursing, the physiotherapy, everyone bringing a separate skill, but not overlapping, but working together to create an environment for evidence-based practice. Now, the team, the multidisciplinary team, also envisions a standard set of goals to be shared by the providers of care for the benefit of the patient. So, there is always a criticism what we do in research. In a population-based research cannot be applied to an individual patient. But then when you have this research and the evidence and you apply it with taking patient as the central point, taking patient's values and preferences, it can be the best holistic method of treatment and management of the patient. I'll just show you what we already know, the different partners in the multidisciplinary team. We always keep talking about our physicians and nurses, but there are also other partners such as the respiratory care practitioners, the physiotherapists, the psychologists and counselors, the nutritionists, the social workers, and also the end-of-life carers. All these people are important, and they also bring in their evidence of what they practice into the care of patients. This is a schematic just showing how a patient is being managed who is having Parkinsonism. You have a doctor with special interest in Parkinsonism or a family doctor who has got close contact with the patient and then coordinates with the various other people such as the neurologist, the nurses, the occupational therapists, psychologists, speech and language therapists, pharmacists, and etc. So this is a kind of multidisciplinary approach which will eventually benefit a patient, and evidence-based practice will come into action. Here, the central role is a family doctor, but this may change. In the hospital setting, it may be that it is the nurse who is taking the leadership position. And I'll show you examples for that as we go on. This person you already know, especially our colleagues from Canada, know David Sackett, was also Diane McMaster, who started off, along with Guyton, the evidence-based practice. What is this? Is the evidence card. What he used to do was a just-in-time learning, which started off then in an old system in 1990s. They took the cart along. They used to use the CD-ROMs instead of, we didn't have the net then. CD-ROMs, books, whatever, went through the patient, looked up relevant portions regarding treatment and management of the patient. It took them about 1.5 minutes, but it changed about 1/3 of treatment decisions at that time. The rounds took longer. This is something else. So we have this card now. We also have portable laptops nowadays, but then the current state of IT. We have this lovely shiny car, red Ferrari looking like all dollars in the wheel, costly. What they say, can it track data? No, but it's fast, and you know what. So that's not be the state of our IT today. We need a fast IT, but jokes apart, what they do is very important. We have computerized decision support systems which are available, can be made available by particular hospitals in that system, where any staff can log in, check out medications, data, practice in an instant at their fingertip. For this, we need the IT to be very good. But how to incorporate it into our system is still a problem. We have incorporation of medical records already. We have also probably e-pharmacy systems which are working, but they need continuous monitoring, continuous improvement. I'll also talk a few words about these, what is known as evidence-based librarianship and CME. It was earlier mentioned, we need, when you gather evidence, a robust library where they are able to sift through the volumes and volumes of research and bring out what is relevant and what is validated and what is applicable to our situation, our patients. And then you look at it if the patient prefers it or the patient's value, how it comes along. Then you use it. You don't really have to push it down to everybody. That's how it works. And there's something called POEMS. I just learned it recently. It's something where people are talking about patient-oriented evidence that matters. And it's being done only by the general physicians at the moment, I think, in Canada. But it might be something which is going to be very relevant if each of our specialties have these kind of bulletins which is sent out to all the doctors based on the recent research, and that's quite nice thing to look at. Another important factor for the multidisciplinary team is the effective communication. We prefer that